joints, but what did it do in the joints? What? It provided lubrication. It provided nutrients to the articular cartilages and whatnot, yeah. Okay, the fluid that we find in the space between the parietal and visceral pericardium is going to act as a lubricating agent. You gotta stop and think, the heart is beating 24 hours a day, 7 days a week. Actually, from very early on in your embryonic development up until the day you die. It's in constant motion. The chance for friction building up and potentially causing damage then is great. Encasing it in this double-layered pericardial sac with this fluid in between to reduce friction helps prevent it from damaging itself against the lungs, the sternum, the vertebral column posteriorly. All right. Fact of the matter is, if that pericardium becomes inflamed, and this can happen with bacterial infections, with viral infections, or, you know, there's lots and lots of people going around coughing a lot right now. Yeah.
So when they say heartburn, is that necessarily
Heart what?
heartburn?
No, no, that's something totally different. That deals with digestive system. If we do anything to cause an inflammation in this pericardium, it's going to increase friction. If you ever had a really, really, really bad cold, and you've been coughing and coughing and coughing and coughing, actually, no, we'll deal with that aspect of it later. If we have a bacterial or viral infection of the pericardium, don't worry about the cold thing. We'll deal with that in respiratory. The inflammation, they call it pericarditis, and the inflammation causes, when the heart beats, those two aspects of membrane to rub. When they rub, they generate friction, and that increases the inflammation. It stimulates nociceptors. Nociceptors being receptors for what?
Pain.
Pain. Impulses are sent to the brain, and you know what? It's really incredibly scary for the person having this, because there is no way for you to differentiate between that and the pain from a heart attack. To the subject, it feels exactly the same, because of all that convergence in those pain pathways. All right? If it's allowed to go on for an excessive length of time, you run the risk of actually doing serious damage to the heart. But this is something that does happen to people. And when we talk about pericarditis, it's an inflammation of this pericardial sac, and what it does is it increases friction when the heart's beating.
So you're saying that's the same pain someone would feel if they're having a heart attack?
Yeah. Subject would not be able to differentiate one from the other.
But why would there be friction if there is that pericardial fluid?
If the membranes are inflamed, then they start rubbing against each other.
Oh, okay.
This is with reference to an inflammation. Okay, another aspect of this that I want to at least briefly mention, because it's going to be necessary for those of you going on into physiology classes. When we look at, I don't know, cardiac muscle fibers, thinking back to the way those things looked in lab when you guys were doing histology, muscular tissues. Cardiac muscle fibers are highly branched. They're the only highly branched muscle fibers in the human body. They also they were striated, and they had another thing that was characteristic. It was a diagnostic characteristic of cardiac muscle, and that was what?
Intercalated discs.
Intercalated discs. Yeah. Cardiac muscle fibers, when they butt up against each other end to end, when you look at it under the microscope, it looks like there's kind of a straight line where this happens. That's actually not the case. We have actually a juncture kind of like this. When you guys looked at intercalated discs, this is what you were actually seeing. At each of these points of contact, here, 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 and here. We have cellular junctions that we called desmosomes. These are relatively strong junctions holding the cells together end to end. And you notice we got a little offset here. In this offset here is where we have gap junctions. You guys remember that single unit smooth muscle has gap junctions and cardiac muscle has gap junctions. The difference is in cardiac muscle, the only place the gap junctions are going to occur is right here in the intercalated disc, nowhere else. That's real important because that essentially defines how an impulse is going to be conducted from one fiber to the next. You're going to have predictable directions. These depolarizations of the membranes are going to travel going from one cell to the next cell. It's always going to be by way of the intercalated disc because that's the only place we have the gap junctions. If you would, have a look, because it also relates to this aspect of it. There we go. Have a look at pages 562 and 563. All right, we're going to look at 563 first, and then we'll go back and talk a little bit about 562. On 563, in figure 21.12a, you see a diagrammatic representation of the heart, yes? And in that, hey, gang, you know, skeletal muscle, there were 3 different kinds of skeletal muscle fibers, right? And in smooth muscle, there were 2 different kinds of muscle fibers, right? In cardiac muscle, there's 3 again. We have muscle fibers, for the purpose of what we're doing in here, we'll call them pacemaker cells, pacemaker fibers. We have conducting fibers. And then we have the main contractile fibers. These are all kinds of cardiac muscle. The pacemaker fibers are kind of interesting. You know, when we talked about nervous system, and when we talked about muscular system, we talked about things like nerve impulses, being a depolarization running along a fiber in a neuron. We talked about depolarization of membrane in the sarcolemma of muscle fibers, yes? Well, these pacemaker cells are kind of interesting because they self-depolarize. They do not require any outside stimulus at all. They will automatically depolarize in a specific timing on their own. Okay, this is real important. Gang, you can literally sever every single neural connection to the heart, and the heart will still beat. With no neural connections at all. The nervous system and cardiac muscle does not initiate the contractions. This is done by pacemaker cells. The only thing the nervous system is going to do, and that goes back to when we talked about sympathetic and parasympathetic divisions of the autonomic nervous system. Okay, parasympathetic and sympathetic fibers are going to stimulate clusters of these pacemaker cells, not to cause a contraction, but to either speed them up or slow them down. That's it. These pacemaker fibers then, they're pretty much distributed throughout the heart, but you've got 2 really big clusters. They're called nodes. On that diagram, you see labeled out the sinoatrial node, but they're abbreviating SA. You're not going to abbreviate it SA on an exam or anything. You're going to write sinoatrial node, which is up near the base of the superior vena cava at it carefully, it's right at the base of the superior vena cava, in the myocardium, the muscular part of the heart wall of the right atrium. All right. Sinoatrial node is, in most cases, considered to be kind of the pacemaker of the heart. It's what's going to set the overall pace. As these pacemaker fibers that make up the sinoatrial node depolarize, that depolarization is going to be sent to other parts of the heart by way of conducting fibers. And you see, coming out of that, purple lines that are representing conducting fibers. And they've got those labeled as internodal pathways. There's actually another one that they don't have on there. Internodal pathways go from the sinoatrial node to the next node, which would be the atrioventricular node. An atrioventricular node is going to be right where the interventricular septum meets the right atrium. Now, there's another set of fibers they don't show on there, but I want you to be aware of. Another set of conducting fibers. They go to the myocardium of not just the right atrium, but the left atrium as well. And they call those interatrial fibers. These interatrial fibers are going to stimulate the contractile fibers in both the right and left atrium at the same time to contract. Now, as you look at this, look at the far right-hand side of that page. See a series of figures, right? See the sinoatrial node labeled up at the top in figure 1, and see the purple radiating out from that in figure 2? That's the pattern of this depolarization of both the right and left atria by way of those interatrial fibers. At the same time, internodal fibers are carrying this impulse to the sinoatrial node. Just like in skeletal muscle, depolarization just precedes contraction of the muscle fibers. So as soon as the atria are depolarized, contraction is going to occur, and hey, think about the position here. Sinoatrial node's right up there on top, yes? Where are the first contractile fibers then probably going to be contracting? Where? At the top, yeah! The atria contract from the top down. Okay, you remember when you guys went through and learned the flow of blood through the heart. Thinking about the way the heart's set up, we're wanting to push blood from the atrium, each atrium, into the ventricle through the atrioventricular valves, yes? Contracting the atrium from the top down is going to be a far more efficient way to do this than from the bottom up. Yeah? We're getting the blood moving in the direction we want it to go. Okay, so what about these internodal fibers in this sinoatrial node that you see? The sinoatrial node is another mass of pacemaker fibers, but the timing is offset a little bit. It's going to primarily act as a delay. It is primarily going to act as a delay. It's going to take the impulse coming from the internodal fibers and slow it down. Now, logically, if you think about it, don't memorize, think about it for a second. Logically, why would that be absolutely necessary?
To have the pacemakers?
To have that sinoatrial node acting as a delay.
So
Like,
that doesn't
to
fill
fill
that
in
as
with
well.
What?
To fill the atrium with blood.
No?
So the ventricles have time to fill the blood, they get stimulated and contract.
Ah. You want the ventricles to fill with blood and the atria to be completely contracted before the ventricles contract. If you stimulate the atria and ventricles both at the same time, the heart's just going to sit there and quiver you're gonna move almost no blood at all, and you will die. You need to make sure these things are synchronized with each other. Well, we'll get into that in a second. But that atrioventricular node then acts as a delay for the impulse. And then, looking at figure A again, coming out of the atrioventricular node, you see a bundle of conducting fibers. And that bundle of conducting fibers is what they call the atrioventricular bundle. Okay, those of you that maybe had this before, if they were using an old book, the old name for that is bundle of His, H-I-S. But that's proper noun, and they're trying to eliminate those. So that's beginning to fall into disuse. It's now being referred to as the atrioventricular bundle. And in the interventricular septum, the atrioventricular bundle branches into two big branches. And those, oddly enough, are called bundle branches. Those two bundle branches proceed down through the interventricular septum to the apex of the heart, and at the apex, one branch goes up into the myocardium of the outer wall of each ventricle. And there's little bitty branches coming off of those bundle branches. And those are what they're labeling as Purkinje fibers. The Purkinje fibers are directly going to stimulate the contractile fibers in the walls of the ventricles. All right, here again, I want you to think about the pattern of contraction, because this is important. You look on the other side there, the purple is showing where the depolarization goes through the interventricular septum. Then the apex depolarizes, and from the apex you depolarize back up toward the base of the heart. Where are the great arteries coming out of the left and right ventricles? Where are they going to be located on the heart? With respect to the base and apex.
Where's what?
The big arteries coming out of the ventricles of the heart. What is the top? That would be the base. Heart's more or less triangular, yes? Apex would be the pointy end. We want contraction of the ventricles going toward those vessels, not away from them. If you look at the pattern here, that's the way contraction is going to occur. Now, one of the things they don't show you in this book is that in the ventricles, around the outside of both ventricles, the contractile muscle fibers are actually spiraled a bit. So it's not a straight contraction, it's a twisting contraction. It's almost like it's wringing the ventricles out. And that just facilitates a larger amount of the blood in the ventricles being forced on up into either the pulmonary trunk or the aorta. Okay, this pattern. Nursing students, thou shalt know this pattern, or your lives are forfeit right after the life of your patient. Gang, when they do an electrocardiogram, they are not showing action potentials. They are not showing contractions. They're showing overall electrical activity in the heart. If you don't put leads in the proper places, electrical activity occurs in specific directions. It screws up the way it's represented on the graph that you think of as an electrocardiogram. And that leads to false results. So, pretty much everybody in nursing learns how to set up an electrocardiogram on a patient, because it's one of the things you wind up having to do at one point or another. And in some cases, you end up having to monitor them and have some idea of what they mean. Okay, so for getting into what they mean, then I'll leave for physiology. But you've got a definite pattern of depolarizations that occur here. And from the graphs that you get on the electrocardiogram, you can derive a whole lot of information about if there's a problem, and if there is, where the problem is specifically, based on knowing how this conduction system is set up. All right? Everything has to be done with a specific set of timing. Now, this sinoatrial node that we think of as the pacemaker of the heart, it's possible to either have it damaged or have one of the conducting pathways damaged and have to artificially then go in and set up a new set of sequences. And they do this by installing what? A pacemaker. Yeah. Pacemakers are cool. They really are. A friend of mine's father had one put in a few years ago. And they put it right up in here, right underneath the skin. And basically what it is a battery-powered electric device that has wires that will then run to the appropriate parts of the heart, and it generates little millivolt electric discharges to resynchronize the heart. Now, it used to be, back in the olden days, that they just sent out an impulse on a certain timing. Now, and this friend of mine also taught anatomy and physiology. And when the doctor was explaining it to him, because his father was really quite elderly, he said, yeah, these new ones can actually determine biophysical need in the individual and alter heart rate with respect to activities the individual is doing. Not just set a set pattern, but actually then speed it up or slow it down as the person needs it to. Oh, that's really neat. And it's programmable over the phone. You can take and call your cardiologist and hold the phone up to where the pacemaker is, and they send a set of tones through it, and they can actually alter the programming. They can talk to it. Well, you know, when I was told this by my friend, I said, man, that's really cool. How does it determine biological need for speeding up or slowing down the heart? And he said, no, I asked that exact same question. And the cardiologist, who makes like more than everybody in this room combined, looked at him and with a completely straight face, this is one of the reasons you guys have to learn what you think maybe more than what you mean to. We really don't want you being one of these people. This cardiologist that was going to perform a $250,000 surgery said, oh, I just put them in, I don't know how they work. He's also the one that was going to be altering programming on it. Don't really know what it's detecting or how that's working, but I put them in and follow the directions on changing the programming. How much confidence would you have if you were the one going under the knife in that particular individual? Yeah? This happened here in Kansas City, not really all that terribly long ago. So, again, a little understanding of how this system works actually will help in a lot of things you end up doing later on. Now, on page 562, you see labeled out what they call the cardiac cycle, and that relates to this conduction system. Realistically, these images should have been switched with regard to which page which was on. The cardiac cycle shows you sequence of contractions and relaxations. A contraction in any chamber of the heart is referred to as systole. Relaxation of any chamber of the heart is referred to as diastole. And you see those in the labels on this diagram, yes? Systole is contraction, diastole is relaxation. Okay, the way it's going to work then in the cardiac cycle, you're going to start out, we're going to assume that both atria have filled with blood, so atrial systole is going to begin. And that atrial systole is gonna be forcing blood toward the ventricles through the atrioventricular valves. Both atria undergo systole at the same time. There's not gonna be any offset on these, they're both gonna happen at the same time. The ventricles fill up and stretch, and then in B there, you see atrial systole ending. And when atrial systole ends, the atrium begins relaxing and diastole is going to start occurring in the atrium. Well, at that point, the ventricle begins, each ventricle begins undergoing systole. Ventricular contraction occurs. As ventricular contraction occurs, we're going to build up pressure in the ventricles until those semilunar valves are literally blown open. And pressure in the ventricles exceeds pressure in the artery that the ventricle is forcing blood out toward, the valve opens. It's literally forced open by the fluid pressure. Yes?
Did you say both atriums contract at the same time?
Yes. And both ventricles are going to undergo systole at the same time. Also, as the ventricles contract, as they undergo systole, as blood surges back toward the atrium, those atrioventricular valves are forced closed by the blood pressure in the ventricle. So we're going to close the valves going into the ventricles and then build up enough pressure to force the valves open going into the arteries. When the semilunar valves open, ventricular systole continues and blood is ejected into either the pulmonary trunk or the aorta, whichever side of the heart you happen to be on. Now, something I want you to take note of. Look at F. And look at the diagram there, and look at the arrows associated with that. Okay? Ventricular diastole is beginning. And as ventricular diastole begins, pressure in the ventricle drops off, and that allows those atrioventricular valves to open. Pressure was the only thing holding them closed. At the same time, as ventricular diastole begins, semilunar valves are going to be forced closed to prevent blood from leaking back into the heart from either the aorta or the pulmonary trunk. Atrial systole has not begun yet. When you're looking at F on that diagram, atrial systole hasn't started. But you notice there's an arrow and each of the ventricles where you see blood moving from the atria to the ventricles. Why? Those atrioventricular valves at this point have just kind of fallen open. So blood coming in from the superior vena cava and the inferior vena cava and from the coronary sinus into that right atrium, as an example, flows into the atrium and passively flows into the ventricle as well. Think about something, gang. You guys have looked at real hearts and at the heart models. Which chamber was bigger, the atrium or the ventricle on each side? The ventricle. Well, how can we get enough blood to fill the ventricle if the atrium is smaller? The answer is the ventricle begins filling before atrial systole begins. Atrial systole just forces an added volume of blood into the ventricle, causing it to stretch more. All right? Well, you know, when ventricular systole begins, the atrioventricular valves close. There are two sounds associated with the heart. They call it a lupped up sound. The first sound is caused as those atrioventricular valves close. It is not an impact from the closure of the valves. Instead, it is turbulence noise as the valves close. Best example I can give you guys you would have experience with. If, say you've got your garden hose out and you're watering the lawn, you don't have a nozzle or anything on it, and the garden hose is stretched out, say, across the sidewalk, You walk along the sidewalk and you step on the hose. You compress the hose a bit, yes? When water's going through the hose normally, what's it sound like? What do you hear? You guys have all been around a garden hose before. What do you hear in the hose? You don't hear anything. But when you step on that hose while the water's turned on the sidewalk and compress it, do you hear anything? You hear kind of a rushing sound. Why? By compressing the hose, you create turbulence in the water flow inside the hose. And that turbulence makes noise. As these valves start to close, they're decreasing the diameter of the opening, and that creates turbulence in the blood. When you listen to someone's heart with a stethoscope, you're listening to turbulence sounds. You're not listening to the sound of the contraction. You're not listening to valves impacting. You're listening to turbulence created as the valves close. The first sound is turbulence created by closure of the atrioventricular valves. The second sound is created by closure of the semilunar valves as ventricular diastole begins. And what you're hearing is turbulence noise. Here again, any of you that are going into any field where you have to take a stethoscope and listen to someone's heart, where you have to, take someone's blood pressure. This is a concept you have to be aware of, yes.
And those sounds are what we refer to as a heartbeat?
Yeah, basically. At least the auditory sound you hear, yeah. So, compressing any kind of a fluid flow is going to create turbulence, which is going to make noise. And those are the sounds you hear when you're listening to someone's heartbeat. And it's loud enough, you can just put your ear up against someone's chest and hear it. You don't need a special device. They use stethoscopes because A, you can hear better, and B, putting your ear against someone's chest is a little intrusive. Yeah? So, I am not going to have you interpret an EKG, but I want you to know about the conduction system and about the cardiac cycle with regard to this exam. Now, that then will finish the material for this exam. It will cover through the heart and cardiovascular system. Blood vessels will be on the next one. That's what we'll start out with. So let's see here. If memory serves, we've got the brain, we've got the sensory chapter, we've got the chapter on autonomics, what little we did, and you're only going to be responsible for what we did in class on endocrine, and then blood in the heart. Hardly anything at all. For our very next banquet of learning, which is Monday? Tuesday, yeah, Tuesday, sorry. I have Monday, Wednesday classes as well. So Tuesday of next week, there will be an open lab, by the way, from 1 to 5 tomorrow. Yes?
Can I ask a question about heart?
That's fine.
How long after, like, someone dies do you hear the heartbeat? Because you said it doesn't need neural.
It doesn't need neural stimulation, but usually that's one of the indicators that they've died, is that the heart stops.
And not because it stops, like it to contract or whatever?
Well, okay. Death like life, there's different definitions that people have for it. You can be totally brain dead. Essentially, they put sensors on and did an electroencephalograph of you, have a flat line, and still have your heart beating.
Right.
The body is not technically dead. The tissues and cells are still alive. There's just no one home in the processing center. So, as far as the heart beating after death, typically, no, it doesn't. When tissue death occurs, the heart's gonna stop. If you're getting tissue death throughout the body, the heart, it's typically because the heart has stopped, put it that way. Now, the rest of the body does not die the instant the heart stops. If something happens, something traumatic happens that damages or destroys the heart, that does not mean that the tissues of the body die immediately. Actually, many of them can last as much as 10 minutes. In the brain, you have about maybe 4, depending upon the temperature, before tissue death occurs. So if the heart just stops and they can manage to get it restarted, then even though the heart had stopped for a while, I know people say, well, your heart stopped, you were technically dead. Well, not really. All the tissues were still alive because they hadn't become anoxic yet. But they would relatively quickly after that happened, without some extraordinary measures taken.
Will there still be processes in the brain?
Sure.
During the period that the heart stops?
Sure.
Oh.
You can have somebody with their heart stopped and they'll be sitting there looking at you, recognizing what's going on. They'll be conscious actually for a few minutes after the heart stopped in many cases. But very, very rapidly, the brain's gonna succumb to loss of oxygen.
So you're saying like, whenever they have to like do the shock on the